Hello, welcome everyone, and thanks so much for joining us today for this webinar that we're really pleased to be providing with the speaker, Professor Michelle Lockley. So as Lee said, I'm the head of support services, and it's just to let you know, please do get in touch with the support service if there's anything that you'd like to talk through, any questions at all, any information that we can help with, or if you just want to have a general chat, then please do get in touch with us. We're available 10 a.m. to 5 p.m. Monday to Friday, and it's myself and my colleagues Annie and Alice. You can call us on the support line number. You can instant chat through the website, send us a text message, you can email us, and we can also arrange video calls or schedule a support call with you at a convenient time as well. So anything at all that we can help with, please do let us know, and we really like to hear from you. As Lee said, if you've got questions for Michelle today, please do drop them into the Q&A or the chat box. Either one is fine. They're both the little speech bubbles that are down the bottom of your screen. I'll be reading out the questions. If there's some that are quite similar, I might put them together. Just a reminder that Professor Lockley can't offer an individual clinical opinion for anybody today, but she is here to answer the questions on ovarian germ cell tumours. And I hope that you'll find it really useful. Because we're recording, I won't read out any personal identifying information. So I won't read out your name if you drop a question into the chat. So just a reassurance that your privacy will be protected, so that we can put the recording onto the website at a later date. And as Lee said, we'll send you around the link for that, so that you can listen to it again at a convenient time. So I think that's all I needed to say. So I'm delighted to welcome Professor Michelle Lockley, who's the Professor of Medical Oncology at Queen Mary University in London, and she's here to talk today about understanding ovarian germ cell tumours. So I'll hand over to Michelle.
Okay, thank you so much for the invite and the introduction, and I'm really pleased that you've joined the webinar today. So I'm just going to share my screen, so excuse me 1 minute while I... Oh, a cat. Okay. Okay, so thanks again for joining. I just want to sort of just say at the beginning, I've got a bit of a cold today, so if I feel the need to sneeze or blow my nose, I'll spare you, and I'll just go off camera for a bit to do that. So if you see me disappear momentarily, that's what's happened. Okay, so as Anna and Lee have said, I'm a Professor of Medical Oncology. I'm based in Queen Mary University of London, where I spend a lot of time doing basic laboratory research, and I'm also an oncology consultant at University College London. And I have a particular interest in ovarian germ cell tumours and other rare gynecological cancers. But overall, my research is all based around improving treatments for women with ovarian cancer. That's at the centre of everything I do. So today we're going to talk about ovarian germ cell tumours, and thanks for joining. So just a brief background on ovarian cancer. So overall, ovarian cancer is not that uncommon. It's said to be the 5th most common female cancer. And in the UK, we diagnose around about 7,000 women a year with ovarian cancer, which is a funny sort of number to work out what that means to get your head around. But CRUK have broken that down, and so that what it actually means is that every day in the UK, 20 women are diagnosed with ovarian cancer. And so over a woman's lifetime, 1 in 50 women in the UK will develop some kind of ovarian cancer. So if you sort of think about your friendship group, one in, let's assume, half men and women, 1 in every 100 people you know will get ovarian cancer in their lifetime. So it's not an uncommon disease. We also know that 4,000 women die of ovarian cancer every year in the UK, which amounts to 11 women every day. So you can see actually rather a lot of women survive this disease. And actually we're talking about germ cell tumours today, and this group are one of the groups of cancers that have really excellent survival outcomes. So we know that survival in ovarian cancer changes a lot depending on what type of ovarian cancer you have, how old you are when the cancer is diagnosed, and how far the cancer has spread when we first meet you. So germ cell tumours kind of ticks all the good boxes in this. So it's a type of ovarian cancer that has a very good survival. It tends to affect younger women, which overall results in better outcomes. And it tends, when it arises, it normally hasn't spread very far in the body. So there's lots of good things about ovarian germ cell tumour. And if, obviously I don't know who the audience is here today, but often I say to women when I meet them, when they have a germ cell tumour diagnosis, that everything you might know already about ovarian cancer or anything that you read in the news often does not apply to you. They're talking about the much more common subtypes. So if you are someone who's newly diagnosed or a relative of someone who's newly diagnosed, bear in mind ovarian germ cell tumours are different to ovarian cancer overall. Okay, so this is just a slightly out of focus diagram explaining the different subtypes of ovarian cancer. So as a doctor, people sort of say, oh, you just treat ovarian cancer, isn't that a bit limited? But actually there's a huge number of different diseases, different cancers that can occur in the ovary. And someone once told me that in the ovary is the organ with the greatest variety of different malignant diseases. The only thing that has more apparently is hematological cancer. So there are more blood cancers, but when you look at actual organ sites, ovarian cancer has the greatest variety out of any organ. And as you can see, do you see my pointer there, Anna? Is that visible? Yeah. So the vast majority of ovarian cancer are epithelial, and I'll explain a little bit more what we mean when we say epithelial ovarian cancers, and germ cell is a rare subgroup. Okay, so this is just a diagram of the ovary. So as you know, just to orientate you, this is the womb or the uterus with the cervix at the bottom end, and this picture just shows the very top of our vagina. On each side there's an ovary, and as you may remember, each month an egg detaches from the ovary, travels along the fallopian tube and sits in the womb waiting to see if it's going to get fertilized and may one day turn into a baby. So when we do a close-up view of the ovary here, the germ cells are these little cells that sit within the ovary that have the potential, if they meet a sperm, to develop into an embryo and then into a baby. And they sit within this supporting stuff, which is called the stroma, and it's surrounded by a layer which is known as the epithelial layer. So each month, one of these follicles containing the germ cells will burst through the epithelium and then make its journey along the fallopian tube. And so most cancers arise in this epithelial layer, which each month gets ruptured and damaged as the follicle exits it. There are some rare cancers that can happen in the stromal cells, and then the cancers that we're talking about today arrive in these cells here, the germ cells that can become babies. So that's what we mean by the different parts of the ovary. And actually it's quite rare to get cancers in the germ cells, and probably for biology and evolutionary reasons, these are very robust cells that are very protected, because it's about survival of the species and protecting new life. And so these ones are not at all cancer prone, but occasionally cancer can develop in them. Okay, so germ cell tumours develop in these germ cells that can develop in women into eggs and in men into sperm. So they most commonly develop in the ovary or the testis. And actually, it's much more common for them to arrive in the testis. So when women have ovarian cancer, it nearly always is not a germ cell tumour. But when men have testicular cancer, it almost always is a germ cell tumour. And so these diseases are much more common in the testis. And a lot of what we know about how they behave in women and how to treat them in women is derived from knowledge that we've acquired in treating men. And this just emphasises, there's quite a full graph. I've just put a box around the important bit for today, the germ cells. So it shows the incidence, the proportion of ovarian cancers that are germ cell tumours. And what you're looking at is over time, so from the 90s onwards, all around the world. And so it doesn't matter where you go, over the last 30 years ago, the proportion of ovarian cancers that are germ cell tumours are, between sort of 2 and 5%. So they're rare cancers. But this is what's really important for us, which is that although they're rare, if you're young, they actually become quite common. So if we look at the big graph, first of all, the red line shows us, this is an incidence here, so it shows us how epithelial cancers, the most common type, increase as patients get older. So you can see that during our life, the incidence of the epithelial ovarian cancers goes up and up and up. And this is true of nearly all cancers actually behave this way, that cancer is generally a disease of older age. And so in my clinical practice, where I treat all kinds of ovarian cancers, most of my patients at this age, they're in their 60s and 70s. And in the green, this is the germ cell tumours. So you can see that overall, then it's really low. It's hardly any compared to the epithelial cancers. But if we zoom in on this age group, which we sometimes called AYA, standing for adolescents and young adults, or you might hear the term teenagers and young adults, and they use kind of, the definition of them varies a bit. But basically, in this younger adult age group, you can see that the germ cell tumours really do peak in late teens and early 20s. And so if you're in that age group, a young adult, and you have ovarian cancer, chances are it's a germ cell tumour. So although they're rare overall, when we look at this age group, they're actually the most common type of ovarian cancer that we see. And of course, if you're that age, overall, it's rather an uncommon and deeply frightening time of your life to develop cancer. And those things really change the way we think about the management of these two diseases, which I'll talk about a bit more today. So the good news, which I've alluded to already, is that germ cell tumours have, in cancer terms, a really truly fantastic survival. So this is just some quite old data. I'm looking at a lot of people who had germ cell tumours, and I'll show you a couple of slides that look like this today. So what you're looking at is survival. So here, 100% survival. All patients in this series are alive. And as time goes along, and some patients, patients sadly die, you see the graph go down. But the sort of message from this graph really is that over time, more than 80% of patients are alive. And this is all germ cell tumours. So a lot of subgroups within this will do very much better than that. And this is quite old data, and things have got even better since then. But the other thing that's important to note is that if people are going to relapse from a germ cell tumour, it normally happens within the first year or two. So in nearly all cases, we kind of effectively give people the all clear after a couple of years, which is unusual in cancer terms. Having said that, we tend to, well, in my practice, I keep seeing people for up to 10 years just to be on the safe side, because there are these very occasional rare individuals who might have a relapse later than that. But when you compare this to epithelial cancers, this is the same, a similar curve for patients with epithelial cancers. You can see that the survival is really an awful lot worse. So by the time we get to 10 years, nearly all patients with epithelial cancers have died. And so the survival, for our young women with germ cell tumours really is excellent. Okay, so going back to this idea about this is the age distribution again, showing you that these tumours are really diseases of young adults. And this, this gives us some interesting sort of management problems that we have to think about. So in clinical practice, actually, the way we divide up patients is based more around legal age. So if you're under 18, you tend to be looked after by paediatricians. If you're older than 18, you tend to be treated by adult oncologists like me. And so that kind of cutoff completely ignores the biology of this disease. That's the practical and historical sort of separation that is based around legal age, and it is not really based around the biology that we see here. So what that means, when you're treated by adult oncologists, we're used to treating epithelial ovarian cancers in women who have passed their menopause and are towards the end of their life. And so we're very accustomed to doing big operations. We're not terribly worried about removing people's wombs and ovaries because, in women who are at the end of their age, past the menopause, it's much, much less of a problem. We're used to treating older patients, so we think an awful lot about toxicity. We can't use very high dose chemotherapy because older women can't tolerate it, and we're very happy to do lots of follow-up, loads of scans with all the associated, scans obviously expose you to radiation, but if we know we're not going to cure people, we're less concerned about that. And so the culture, if you like, is along these lines. The majority of our patients, we're happy to remove their gynecological organs. We think that they can't tolerate chemotherapy very easily. We're not very worried about exposing them to radiation because the cancer is a bigger risk for them. And so, of course, when we're treating younger women, there's lots of different things that we have to take into account. So younger women, of course, the operations that we do in our older women involve big scars down the middle of their abdomen, which we don't want to do to young women. That can have a really big impact on people's body image and how they feel about themselves and their future. Thinking about fertility is, of absolute paramount importance. We have to really think about trying not to make people menopausal when they're young. And the issues about treatment-related toxicity really come to the fore, because of course, if we're going to if we give people a toxicity from our treatment, but we're expecting them to live long lives right out into their 60s and 70s, we don't want to have to endure those side effects over the long term. So in the context of adult oncology, where these tumours are rare, we really need to pay a lot of attention to educating our oncologists and to providing specialist services and expert advice that just emphasises the shift in the way that we think of these things. And in the UK, we're lucky because we have specialist services for teenagers and young adults that look after women in this age group and really prioritise these sorts of concerns. Okay, so just to summarise that part of the talk. So ovarian germ cell tumours are rare. They have a peak, They peak in incidence in teenagers and young adults. The survival is excellent, but there are unique challenges when we treat women in this age group. And most of our learning has come from testicular cancer or from trials in children. And so the big question we have when we try to learn about these much rarer ovarian germ cell tumours is, can we extrapolate? Can we take the learning from testicular cancer and from paediatrics, and can we use that to make outcomes better for women? So today I'm going to talk a little bit about the clinical features of the disease, a tiny bit of biology, a little bit on how we treat, but really I'm going to talk about two big issues that we're actively researching. The first is, can we reduce the side effects of treatment? And does age matter? Does the way these diseases behave change as women age? And then finally, just a little bit of a call to arms. Okay, so I've told you they're rare, but even within this rare subtype, there are still all of these are all different subtypes of germ cell tumours. And some of you on the call may have been told that you've been diagnosed with one of these, or you may be aware of some of these differences. But I'm not going to go too much into detail on this today, but as we learn more about these different subtypes of germ cell tumours, we learn more that we may be able to treat them differently. And I think that's really an emerging field and something to look for to the future. I will talk a little bit more about dysgerminoma today than the others, so just to highlight that. So in order to understand whether we can treat these diseases differently, we probably need to understand the underlying biology a little bit better. Now, I'm not going to get too technical, and I've really just included this slide just because sometimes it's not great to have a rare cancer. You can sometimes feel that there's not much known about it, and there's not really a body of people really working on understanding it more. And so I just thought I'd put a little bit of nuts and bolts technical biology stuff to show you that there are people who are interested in finding out how these things work, and that we're finding out more about the genetics and the biology of these diseases. But really, the next thing I wanted to sort of emphasize is when this just refers to changes in the DNA within the tumours and how the tumours develop. And what we're learning more and more is that a lot of these features are also found in male cancers. And the important thing for me as an adult oncologist is to try and understand whether these changes in biology change as we go through life. And so whether when in the even less common older women who have these diseases, can we think about them in the same way as we think about the children where these diseases are more common? Okay, so this is just a bit about how these cancers present, which is different from the other kind of ovarian cancers. So in general, when people are diagnosed, the most common stage of disease is that the cancer is only within the ovary, so it hasn't spread beyond that. In the epithelial cancers, it's very common that they've spread or metastasized all around the body, and it makes them rather more challenging to treat. But germ cell tumours normally stay within the ovary. And this is another difference between ovary and testis, that testicular cancers also stay within the testis, but there's a limit to how big a tumour can get when it's in the testis. But when a tumour's in the ovary, as we all know, our bodies are capable of accommodating things the size of a baby within the pelvis. And so these tumours can grow to be quite big. And here is just an example. This is an MRI scan of a patient. So when we look at an MRI scan along here down this side, this is the spine. You can see the spinal discs in between the vertebrae. This is her tummy, and she's sort of sliced like side on. And this here, this big mass, this is the same thing, just shown in different ways. It's a big ovarian tumour. And so it's got to a large size. You can't imagine that a testis cancer could ever get as big as this. And it's starting to actually make a tummy stick out. So most patients you can imagine that's not very comfortable. So it's very common that people come to us with some pain and some swelling. Sometimes they can be in really severe pain, or we would describe medically as an acute abdomen that might end up with them coming into A&E in quite severe pain. But most commonly, it's this sort of swelling, discomfort, and it's surprising just how large these tumours can be when they first come. So the treatment is to take them out. It hasn't spread beyond the ovary, so in most cases, the surgery is possible. It does usually involve removing one ovary, but in all cases, the aim is to spare people's fertility. So, our aim always is to leave women with at least one ovary and a uterus, and that's beneficial in terms of thinking about reproductive, future reproduction, and also to prevent early menopause. So this is different from other ovarian cancers where this is not so much of a concern. And then in many cases, if the cancer is just within the ovary, that could very well be enough treatment that you've taken it out, and patients don't need any treatment after that. So some of the other things you hear about in cancer care, like chemotherapy and radiotherapy, may very well not be required. But there are some published guidelines on how we should look after people after the operation and how we should keep an eye on them to see whether it's come back or not. And this is a table from a paper that tells us what to do. And it's actually quite intense. So we talk about seeing women very regularly, examining them very regularly, every 2 to 3 months, and as time goes on, that gets less and less. I haven't mentioned tumour markers today, but quite often ovarian germ cell tumours produce blood markers that we can measure that are really helpful. So we would, as well as seeing people and examining them, we'd want to do blood tests. But I think these guidelines, I have a couple of concerns about, to be honest, because they suggest lots of CT scans, which exposes people to radiation, where I should say MRI scans and ultrasound scans do not. But this I find a little bit concerning, because we're exposing young women to radiation, and we think we've cured them, and this could potentially, it's just worth considering. I think CTs are appropriate when they're really needed, but in young women who we're curing, I would always try to avoid them wherever possible. And the other thing so sometimes we'll do MRI scans. There's quite a lot of ultrasounds in this follow-up, and sometimes we advise transvaginal scans, which may not always be appropriate for young women, particularly young women who have not yet become sexually active, or even if they have, it might not be something that appeals. So I think this, could be improved and finessed a bit going forwards. Now, if the cancer has spread beyond the ovary, then very often we do advise chemotherapy. And the most standard chemotherapy regimen is called BEP or BEP. And the 3 drugs that are included in this type of chemotherapy, the BEP stands for bleomycin, etoposide, and cisplatin. And this is really quite an intensive chemotherapy regimen. It causes, a certain number of side effects. And so, of course, if a patient has cancer that has spread widely, we know that this chemotherapy regimen works. It is still by far the most proven effective regimen, and we use it a lot. But it does cause some toxicities. The effect on the lung of bleomycin can be problematic, and actually in older women, by which I mean over the age of around about 40, this becomes, quite difficult for older women to tolerate and often is avoided. And drugs like cisplatin, when they're given at high doses, can cause problems like nerve damage, can cause hearing loss. And the paediatricians are very, very attuned to these toxicities, and particularly because in children, if you cause hearing loss in children, you really can adversely affect their life chances and what they can expect to achieve from education and in the workplace, etc. So the paediatricians for a long time have been very, very focused on trying to see are there any modifications to this regimen that can be just as effective as that, because it is extremely effective. It cures people, but can cause less of the long-term toxicities. Okay, so this was the first question that I told you I wanted to talk about a bit today. Can we make chemotherapy treatment less toxic? Okay, and one way that paediatricians already do this is instead of using cisplatin, they use carboplatin instead, which is a very closely related drug, but it doesn't cause the nerve damage and it doesn't cause the hearing loss. This has also been tried in testis cancer. So these are just some more of those graphs like the one at the beginning. And what you're seeing here again is this excellent survival, very few people relapsing and dying over time with testicular cancer. And the overlapping curves just show here that carboplatin in testicular cancer just worked as well as the standard treatments. And here, myself and others have conducted this other study in which we looked at the survival with single agent carboplatin in testis cancer, and you can see it's excellent and comparable to the survival curves I showed you before. So we wondered, if this drug is used by paediatricians, it works in testis cancer, can we also use it in women? And we think it's kind of a rational thing to do, because there's this subtype of ovarian germ cell tumour called dysgerminoma, which basically looks exactly the same as seminoma when we look under the microscope. And when we delve more deeply into the genetics and the DNA, it also looks the same. And clinically, it behaves the same. They're both extremely platinum sensitive diseases, which means that cisplatin and carboplatin work really well. And actually, this similarity between these two diseases has just been recognized in the World Health Organization classification. And so now, rather than thinking of these as different tumors, it puts them all together in the same family of germinomas. Sorry, there's a typo there. But so emphasizing that biologically, we think these two diseases are the same. And so we think there's a rationale for trying carboplatin in dysgerminoma. So we've looked as a group at data from lots of trials which tested chemotherapy containing cisplatin and carboplatin. And there's lots of lines here, so it's a bit difficult to look at. But I think the take-home message here is that all the lines are pretty close together. There doesn't seem to be any difference when carboplatin or cisplatin was used. The majority of patients in this work were children, though. There were a few adults. And this is a problem for us because dysgerminoma and ovarian germ cell tumours are so rare. So compared to the testicular equivalents, there's, the testis one is 10 times more common. And what that means is in rare tumours, it's really quite challenging to do clinical trials because you need a lot of patients, and often you have to collaborate across the world to get buy-in to all of these things. And so it's a real challenge for us to actually make discoveries and learn new things for ovarian germ cell tumours and to test them so that we can actually change treatment. And when we look at, I looked on the website that lists all clinical trials, and when I looked last week, there were 59 trials listed for seminoma patients and only 7 for dysgerminoma. So it's really kind of under-researched, and actually treatment for ovarian germ cell tumours really hasn't changed much over the years. You know, we still use BEP, and we were using that back in the 90s. However, some of us are quite interested in changing the situation, and this is a paper that I had accepted for publication last week, in which we do quite a lot of work comparing the underlying biology, the genetics, the clinical features of seminoma and dysgerminoma, and sort of telling the same story that I've just told you, that we think they're very similar, and that actually it could potentially be a good idea to include seminoma and dysgerminoma in the same clinical trials. And that it is rational to test using less toxic chemotherapy treatments. So we pitched this idea to a national germ cell tumour group, which historically was a testicular cancer group, but in recent years they've sort of allowed us in, those people who treat ovarian cancers. And we did a session on ovarian cancers in that meeting, and everyone had red and green cards, and we sort of after we told our story, you know, so we asked them if they think it makes sense to include dysgerminoma and seminoma clinical trials, and red was no, and green cards were yes. So you can see slightly blurry photos showing that the National Germ Cell Tumour Group thinks that this is a reasonable idea. So we hope that we're moving towards a situation in which we can conduct clinical trials in more ovarian germ cell tumours, so that we can move and progress things forwards. And so the trial that we're working on at the moment is this trial called the Otis trial. We're trying to get it funded, but I just sort of wanted to let this audience know that, you know, we're out there kind of rooting for you and trying to improve things for you, and it took quite a lot of you know, negotiation really to try and increase access to trials for women with these cancers. We want to look at new technology, we want to understand the biology, and, you know, we really recognise that things haven't improved for decades, nothing's changed, and when we have limited data, we can't really affect change. And so basically, you know, we kind of got talking to people, and we elbowed our way in and gate crashed basically, and we really had to prove that we weren't going to dilute their outcomes, we weren't taking away anything from the testis cancers. And, you know, in return, we've had to accept a bit of a compromise. You know, it's not maybe the perfect trial that we would want, but we're trying increasingly to unite around these similarities. And I think we've got the engagement of the UK national community anyway, so hopefully we can move these issues forwards. Okay, so the next thing I wanted to discuss was this issue of age, and does age matter? So in that, these are predominantly tumours of teenagers and young adults, and when we see them in women who are older, are they different diseases? How does it change how we treat them and how we look after those patients? Okay, so first of all, we look back in our own data from our own hospitals over a 12-year period. We found over that period 138 patients, so that tells you really, it's rather, you know, emphasises how rare these diseases are. And the majority of patients were over the age of 18. So the first question was, did it make any difference if you were older or younger than 18? So as adult oncologists, can we treat our adult patients the same way as the paediatricians treat their patients? And this trial is just showing you, this table is showing you the characteristics of the diseases in patients who are younger than 18 and older than 18. And overall, we didn't see, if you kind of compare column to column, the numbers look approximately the same. There are a couple of subtypes of ovarian cancers. This is immature teratoma, and this is mixed germ cell tumour, that did appear different by age. But in, you know, it's rather a small number of patients, so it's difficult to know if that's true. Survival was the same in patients who were younger than and older than 18. But what we did see is when we looked at women over the age of 40, where the cancers are even more rare, their outcomes actually were rather a lot worse. And so, you know, we're interested in finding out, what is this? Are we not treating them as well, or is the biology indeed different? We've done a much bigger study that we're hoping to publish this year, and this is looking across in, you know, a US population, and we see the same again, that older women over the age of 40 years again have worse outcomes than younger women. And when we looked in those data in a bit more detail, we found that older women were likely to have higher disease stage. And you may remember I sort of mentioned at the beginning that disease stage really matters in outcome. But actually, when we looked stage for stage, older women always did better, sorry, did a bit worse than younger women. Even in stage 1, they did worse. When they were stage 2, they did worse, etc. So stage for stage, older women do worse. Older women are also more likely to have tumour left after their surgery, and they're more likely to have only received surgery or only received chemotherapy, which sort of makes you wonder, are we less aggressive in the way that we treat older women because we think they might not tolerate the side effects as well. But actually, even when we adjusted for those factors, survival was still worse. So it seems that perhaps the underlying biology of the disease in older women is worse than it is in younger women, and this is something that we're actively trying to work out at the moment. So a lot of this work has been done in collaboration with this organisation. It's called MAGIC. It stands for the Malignant Germ Cell Tumour International Collaborative. And what this is a big group of people who come across all the different medical professions that treat germ cell tumours. So we're trying to unify between paediatric oncologists, gynecology oncologists like myself, the people who specialise in testicular cancer, surgeons, pathologists, etc., to try and form a kind of a global group that can really take the field forwards, so that we have these established collaborations that can enable the trials in rare cancers. And this was, it was initiated in 2014, and you can see it was just a tiny group of about 10-15 patients. This is a meeting we had last year in Indiana, and in a couple of weeks' time we're going to meet again in Edinburgh, and now we have 80 delegates. So this is something that is growing. There is movement, and we're really trying to push this forward for all patients with this disease. So we've already conducted a number of clinical trials. I mentioned Otis today, but these other trials with the stars next to them are already recruiting patients. And we're really interested in thinking about these diseases as having the same biology and being inclusive, and making sure that any patient with these diseases can participate in the learning of these trials. So the questions that we're really interested in MAGIC are, can we improve outcomes for those small number of patients who don't do well? And again, in the small number of patients who relapse or have disease where the treatment doesn't work, how can we help those? We're always looking at new ways of treating people, and I probably should have had on here another bullet to say that actually reducing toxicity is really important. Another question that I'm interested in, and how we look after people with these rare cancers effectively within the NHS. And so, can we identify new targets? Can we improve our outcomes? And particularly, relapse-resistant disease in older patients. What we really want to do is collect data from as many patients as we can, so we can learn from people's experiences. We need to be better at collecting samples of people's tumours after they've had an operation, so that we can do more discovery science. And we need the international collaboration for clinical trials. It's a great organisation. It's been really helpful in pushing the field forwards. But I would still say it's kind of US heavy, and we need, better engagement from the rest of the world. It's still a bit testis heavy and paediatrics heavy, and we need still better involvement from more adult oncologists who treat women with ovarian germ cell tumours. So just my last slide, I've talked a lot about the things that we're interested in, where our priorities are on, and how we're trying to push the field forwards. And I'd be super interested to find out, what actually matters to you. And finally, we're always interested in patient input in clinical trials, patient representation in the MAGIC group. Most of our patient reps come from America. So if there's anyone who's interested at all in being involved in an organisation like that, or contributing in any other way, please do, and influencing what we do. Don't let us just go down our own little rabbit holes. Tell us what's important to you guys. A final thank you slide. Some names on there. That's not all the people who have been involved in this.
Thank you so much, Michelle. That's really such an interesting talk. So if anybody has got any questions, please do drop them into the Q&A and the chat, and I'll read them out. And just while people are having a think, Michelle, just wanted to ask you about if people are interested in being involved in clinical trials or being involved in the patient group, should they go to the MAGIC website?
Yeah, they can go to the MAGIC website, or via Ovacome. I mean, this is some of the charities that are interested in Ovacome. I think you've done quite a lot of work on rare cancers, so so I'm sure I'd be very happy to be contacted directly if Ovacome's the easiest way to do that. Then that would be fun.
Yeah, absolutely. So what we can do is, with the email that we circulate round and pass on the recording, we'll include the link for MAGIC. But of course, yeah, absolutely, as Michelle says, please do get in touch with the support service, and we're really happy to send you any information that would be helpful for that as well, and we'll put that on our website. So any questions that are coming in? I think it was such a thorough talk, Michelle. You may have answered everybody's questions, but we'll give them a bit longer. There was a question I had. It was just around, and I know you're saying that relapse isn't common, and it's very treatable in that first line. I wondered, is secondary surgery ever a treatment for a relapse, a recurrent?
Yeah, so absolutely it can be, and in some of the subtypes, actually surgery is the mainstay, and we often just sort of, some of them don't respond so well to chemotherapy, and they'll have sort of small bits of cancer cropping up that either we just watch if they're not symptomatic, or sometimes we'd do surgery again. So yes, it can be. I mean, I think with these cancers, there's quite a lot of complexity to them, and so whenever there's a problem, symptoms or relapse or something seen on the scan, we kind of reset, start back to the beginning again, go from first principles, and all options on the table. But yeah, surgery is a big part of the management, and with the mindset that we keep the surgery to a minimum. We only do it when we absolutely have to. We don't interfere with fertility, and we try to be as conservative as we can.
Thank you. And someone's asked, is granulosa cell tumour a germ cell cancer?
No, it's not. So if you recall that the picture that looked like a hand drawing I showed you at the beginning of the ovary, and there were the germ cell tumours, the much more common epithelial tumours of the surroundings, and then there was this stuff in the middle, a supportive tissue called the stroma. So granulosa cell tumours are a cancer that arise in the stromal tissue.
Sure. And someone's asked, are there any trials or anyone looking at speeding up diagnosis for patients with the rare subtypes?
I'm not aware of any in germ cell tumours, and I think in general that's not the major clinical concern, because they nearly always are stage 1. It's very rare that they escape the ovary, so we don't think that picking off any earlier is going to make much difference. It's slightly in testis cancer, there's a lot about self-examination and that kind of thing to try and pick things up when they're smaller, because testicular cancer is a bit more likely to spread, but for ovarian cancers it's not a big concern. It's very rare that they've spread, and so we don't think detecting them earlier will make a huge difference. I mean, what I'm quite interested in is this idea of surveillance when we're watching people afterwards, and the whole purpose of that is to try and detect relapse. And I think we have these protocols that we're meant to follow around the world for how we follow people up, and I just know, as far as I'm aware, no one's actually tested how good they are. No one's looked at the patient experience. No one's looked at do we need to follow them up that aggressively? Do we need to do more? So that sort of early detection, detection of relapse, I think would be a really good thing to look at, but I don't think anyone's doing it. One thing we are doing as part of the trials is there are these new blood markers that have been developed in testicular cancer, and we want to test them in ovarian cancers, because that would be a a less invasive, potentially less costly way that you could measure very frequently for recurrence.
Oh, thanks, Michelle. That's really interesting. Someone's asked, the collaboration across testicular and ovarian germ cell cancers seems excellent to me. Are other subtypes of ovarian cancer being researched through collaboration? I have clear cell and I'm aware other locations can develop clear cell.
So there is generally a move in like all of cancer care to think about, the biology of the cancer. So clear cell cancer, definitely you can get in the ovary and you can get in the endometrium and in the kidney, as you rightly point out. There are certainly clinical trials now that will include patients with all versions. So we've just done a trial in the UK that included ovarian and endometrial clear cell, looking at immunotherapy and ovarian and endometrial clear cell cancer. So it's moving that way, that clinical trial collaboratives are basing trial enrollment on a biological feature, the histology or even sometimes a genetic mutation. So that enables you to take part in a trial rather than just, the label that you have, more the biology.
Thank you, Michelle. Any other questions? And just while we're waiting, I'll just ask another question. So Michelle, you were saying that germ cells seen in a much younger age group, and so fertility preservation is an important option as part of that treatment. If people are concerned, at that diagnosis things, and they want to have those conversations around their fertility choices, who should they approach in the first instance to start exploring what their options are with that?
So it depends. The precise service will depend on where you're treated, but normally the operating guy. Actually, I should say that everyone in the team should have an understanding of this. Everyone's treating like ovarian cancer; they should have some understanding. But often the people who are with most expertise are the gynecological surgeons, and they're often linked into specific local fertility services. In most cases, it's okay because we try to do operations that don't compromise someone's fertility, and although chemotherapy, as I'm sure many of you are aware, can affect fertility temporarily, and we do see with BEP chemotherapy, people's periods often stop for a period afterwards and then start up again. But in general, and it's very difficult to quantify how much it affects fertility because you never know how fertile someone was before they even started with the cancer. But we see a large number of successful pregnancies after treatment for germ cell tumours, and we've got patients in our clinic who now come in with their babies on their 10-year follow-up. So yes, it's really important. In general, we don't affect fertility too much. But if you're concerned, go via your oncologist or your gynecologist, and they'll be able to tie you in with local fertility services.
Right. Thank you very much. But any other questions for Michelle? Let's see. Okay. Well, yes. So as I said, super clear talk and very many thanks. So that's great. Michelle, was there anything that you wanted to sort of add in before we finish at all?
No, I just emphasize, if you're interested in or have capacity, it's your thing to get involved, please do reach out because we value patient influence and hearing your voice a lot. We're at a bit of a new stage with these kinds of international collaborations, and if you want to get involved, please do as much as little as you want. Great.
Yeah, that's great. Thank you ever so much. And Lee, was there anything before we finished at all?
Thank you so much for the talk, Michelle. Really informative. Thank you.
Not at all. Thank you for the invite.